So, doctor, you yourself are a cancer survivor,
Yep.
and what do you believe the steps should be taken to bridge the gap between the research and the clinical practices, ensuring that the promising discoveries and advancements are effectively translated into meaningful treatments for patients?
Okay, that's a very interesting question. So as a cancer survivor, I actually had acute lymphoblastic leukemia, a disease with a high risk of me dying, particularly at the age that I had it. Ironically, I'd trained initially in hematological oncology and treated a lot of patients with leukemias and lymphoma and other hematological malignancies. This is where I gained my passion for research and trying to address questions for improving care in patients. And then when I became a breast cancer oncologist, I realized I didn't really know a lot about breast cancer, unlike my more senior colleagues who seemed to think they knew everything about breast cancer and how it would behave. And therefore I embarked on doing clinical trials, or find the answers to the questions that I didn't know, but then it transpired that most people don't know the answers to these questions. And my colleagues who thought they did know the answers were actually unique in the fact that they could interpret how our cancers would behave. I think that's what we have to realize. We have to recognize the gaps in our knowledge and trying to fill those gaps, and to build systems where we do research systematically. And that's what I embarked on in 2001. And then the next challenge was getting those treatments into the care system, actually engaging with commissioners and redesigning services, because the new treatments were bringing extra pressures and we didn't have the people on the ground to do it. So it's a continuum of finding a question that you want to ask, working to get the answer, but once you've got the information, you have to translate that into a sensible way of treating patients. And of course, that then leads to new questions. So it's a never-ending spiral, hopefully upwards and not downwards. So cancer is a word that terrifies many people, and it's hard to come to terms with your mortality very quickly, because breast cancer is obviously often found either by the person themselves as a lump. Ideas go through their head, they get scared, they get a diagnosis. I think the first thing to point out is that for most people who have a lump in their breast, they do not have breast cancer, and it's very important that you find that out quickly. But even more important that you find out if you have breast cancer quickly, because then it can be treated far more effectively. I'm pleased to say over the 20 years I've been practicing breast cancer, it's changed enormously, and we cure far more people. We have better ways of understanding different breast cancers and treating them more effectively. For instance, when I started as a breast cancer consultant in 2001, HER2-positive breast cancer was considered the worst breast cancer, but it's now considered probably the best breast cancer because the treatments are so effective. And I'm very pleased that I was involved in many of the trials developing those drugs, but also in getting them into practice by commissioning routes and through, in later days, talking to NICE, the clinical excellence body in the UK that gets treatments into practice.
So, when we speak about new cancer treatments and technologies, do you think that the patient experiences and the suggestions are play a role in implementing these new cancer treatments?
Very much so. We've moved from cancer diagnoses being as terrible as they might be, although obviously within the person who has been told they have cancer, it's devastating. But treatments are so much better now. And we have to think about what people in society want out of treatments. So in the UK, we insist that all trials that we develop in our academic centres and through our national funding programmes have patient involvement. And one particular trial that I'm very proud of, which is called HER2 Radical, which I conceived and led to funding, involves trying to reduce therapy for patients who've had a fantastic response to HER2-directed therapies and chemotherapy before surgery, and the cancer seems to be completely eradicated. Do those patients need all of the treatment that they currently get. So we're trying to investigate whether we can reduce some of those therapies and the side effects of those treatments.
We are seeing a lot of changes, a lot of advancements in treatment policies or treatments, basically. So how do you think that telemedicine and remote monitoring will help or contribute to transforming the cancer care delivery?
So that's a very good question. Telemedicine and AI. So the burgeoning of new treatments mean that there are more and more treatments that are increasing at a rate of about 10% in deliveries of new treatments every year. Unfortunately, the clinical staff to support and deliver those treatments hasn't increased. And we see even in places like the UK, there's huge inequity of access to the right people to discuss your treatment with. And therefore, I think telemedicine is hugely beneficial, that you may well be able to access an expert in the cancer that you want to talk about. And with that, in the Outreach Research and Innovation Group, that is one of the services we provide, access to the best clinical opinion to be able to discuss whether you are on the right treatment, and if not, where you might be able to access that.
The clinical trials, it plays a very crucial role in advancing the cancer care. And what are some of the key challenges in patient recruitment and participation in these clinical trials?
So that's a very important question. Clinical trials and integrating them into the care pathway. This was the model of care that I delivered in 2001 and enabled large numbers of patients to get access to innovative breast cancer treatments. Indeed, in one of the trials I was running, 88% of the people who were suitable for the trial actually went into the trial. That's not the case anymore. We see that, unfortunately, because of the demand and the lack of the appropriate staff to open trials across the UK and probably across the world, there's much less access to clinical trials than there used to be. And I think that's a challenge that we need to try and solve. Outreach Research Innovation Group has a partnership where we can access treatments and trials to patients in the north of England in areas where they didn't traditionally have access. So that's another opportunity that we potentially bring. And we're happy to work across the globe to be able to deliver clinical trials. I think it's fundamental that there's equity of access to clinical trials for all patients in all areas.